Okay, well, thank you all for joining us today on our webinar on the Patient Safety Incident Response Framework, the PSIRF. For those of you that don't know me, I'm Ferenc Gaze, Head of Policy and Public Affairs at NHS Providers, and I'll be chairing today's session. It's a tremendously pressured time for you all, so thank you again for making the time for this. It's obviously one where patient safety is top of mind. Within that context, the PSIRF represents a significant shift in the way the NHS responds to patient safety incidents. And as we're now at something of a midway point through the transition from the Serious Incident Framework to the PSIRF, it seems a timely moment to come together and learn from each other and discuss how implementation is progressing and can best be supported. I'm delighted to welcome our panel today. Mark Smith, patient safety partner, who will be sharing his insights into the importance of the new framework for patients. Lauren Mosley, head of patient safety implementation from NHS England, who will be sharing her insights on what the framework means for provider boards. And Sue Wilkinson, chief nurse at West Suffolk NHS Foundation Trust, who will speak about her experience within a PSIRF early adopter site. And during the Q&A at the end, we'll also be joined by Tracy Hurley, Head of Patient Safety Incident Response Policy, also at NHS England. We'll present for about half an hour or so, and then we'll have plenty of time for questions in the second half of our time together. You're very welcome throughout to add questions and also comments on your experiences so far. You can do that through the Q&A button, which is at the bottom of your screen. You're also very welcome to upvote other people's questions if you had a similar one. The NHS Providers team will be triaging those, drawing out the most popular ones and any common themes. We'll keep a log of those and all your contributions will be anonymous, but you're obviously very welcome as well to add your name and trust if you would like to. We are recording this session and we'll make it available along with the slides afterwards. So to begin, I'd like to welcome Mark and Lauren. Thank you.
Thank you very much indeed. So, can I have the first slide from myself, please? Okay, my involvement was... Next slide. Thank you. My involvement started in 2017 when the National Patient Safety Team were starting to develop a public consultation on how to change the Serious Incident Framework to make it more responsive and to amend some of the issues that were occurring with it. They undertook a consultation in 2018 and it highlighted that the whole system needed to be changed. It couldn't just be a tweak. So that then was the reason it needed a new philosophy and a new approach. PSIRF, or Patient Safety Incident Response Framework, is not a tweak of the Serious Incident Framework. PSIRF is not a new word for Serious Incident Framework. The major difference is now that patients, service users, families, friends, and staff are at the centre of how we look at incidents, events, near misses, and how we can find out the causes and use a quality improvement approach to enable them not to recur. In the PSIRF, you don't just have an investigation response. There's lots of other responses that you can use, which can be more appropriate and can mean that you can give information to patients, family, friends as to what's happened quicker than having a full-blown investigation. The quality improvement should be across the whole organisation. I remember when the early adopters, when the first meeting of early adopters, I found it quite incredible that a patient safety manager was saying, well, we have an incident, we investigate it. A few months later, it occurs exactly the same thing in another speciality or another of our sites, which isn't really a good way of going about it. You want to try to have them not starting again. The framework relies on joint working within and across systems. So you should be working in partnership with your ICBs. It's a key way of working forward. And in the organisation, it's a top-down and bottom-up approach. You've got to be supporting each other. A question came up at one of the other webinars a little while ago, which said, there's tension at the top of our board. How do we reassure them that this is the right thing to do? I think because you're putting patients, service users, family, friend, and your staff at the centre of the response and how you go about it, you will get better responses and better outcomes with your quality improvements. Next slide, please. It's an important change piece. There's been lots of national reports, as well as feedback from staff, patients, families, carers, that highlighted generally that the processes under the Serious Incident Framework didn't generally produce a high quality, system focused outputs. Patients, families, friends, and most importantly, your staff weren't really involved, apart from the people that were doing the investigation as to what was occurring, and they felt unsupported. And the other thing, as I mentioned a little while ago, is there was no real evidence of sustainable change and improvement. The idea behind PSIRF is a movement to change this. The old Serious Incident Framework was process driven. It was a very linear root cause analysis. Repeat investigations were recommending the same sort of action. There was basically two responses came out of the investigations. Either it was a person or staff issue, so you had to retrain the staff, or it was a process issue, so you had to rewrite your processes or procedures. And this caused indirectly blaming the people, staff having to reflect. Staff will be retrained. Staff will be reminded. And this undermines an improving safety culture and a quality improvement framework. We also found that staff had very little time and training to do investigative work, or now with PSIRF, other methods of looking and finding out what the cause of the event or near miss is. There is training requirements as part of PSIRF. And the Serious Incident Framework had become a very bureaucratic and punitive process. And people were comparing the number of serious incidents between organisations as a safety performance measure, which, depending where you are on your improvement train, your improvement journey, those measurements are not really valid. And the other thing as well is your staff will have a lot of their comfort blankets will be removed with under PSIRF. They won't have trigger lists. The statistics they've always relied on won't really mean a great deal. So they do need the support and reassurance from boards in organisations. And remits of investigations became conflated and didn't really do the learning. Next slide, please. This is a very busy slide, and I've actually seen a similar one which had 15 columns, and all different types of investigations that are undertaken by trusts and how they all got mixed together. The patient safety investigation aims to find the contributory factors of what went wrong. How did it go wrong? And there you have your quality improvement program to improve and hopefully reduce the risk of the incident, event, near miss happening again. Lauren.
Thank you, Mark. And good afternoon to everybody. It's great to be here talking to you all about the Patient Safety Incident Response Framework. This is a really important slide, actually, that Mark has just been presented here. And as Mark said, he's been working with us for a long time on PSIRF, but it is so important that under PSIRF we start to protect the remit of safety investigation. This was one of the really key findings of the investigation, of the engagement that we did, where the serious incident framework was trying to answer all sorts of questions for different processes. So whether that be the coroner or claims investigation, we often used to find that serious incident investigations would make judgments about avoidability, preventability, cause of death, and that would move us away from that sort of systems analysis and identify those contributory factors, as Mark has just said. If we could go on to the next slide, please. Thank you. Now, many of you may have seen this bright yellow slide before if you've been to our PSIRF webinars, but we talk about PSIRF now as more of a movement than a framework, and that's to reflect the cultural change that we hope PSIRF will support, but also the fact that we know that PSIRF won't be a change that happens overnight. And hopefully that's reflected in the way that we've tried to support implementation of PSIRF over this sort of period of preparation, which we'll talk about. But it is a big system change, and it won't be something that's even completed within the 12 months of preparation that we often talk about. It will be something that continues to evolve over time, and we're really excited to be on that journey. Really important to mention that PSIRF is not an investigation framework, and that's not to say that the serious incident framework ever was, but it was sometimes perceived as such. So PSIRF is not that, and serious incidents no longer feature within PSIRF, and this is a huge change for the system because serious incidents have been in our dictionary, our patient safety dictionary, for as long as we can all remember, probably. But they brought certain problems and challenges with them. Some of those that Mark's just been describing there, we often used to find that there was lots of debate around what met a serious incident threshold, could actually sometimes cause a lot of tension between provider organisations and commissioning organisations because there were differences of opinion. Often provider organisations were really scrutinised as to where they placed that threshold. For example, in CQC inspections, whether the right threshold had been applied, and that's really difficult to do with hindsight. And also the serious incident as a term, as Mark said, was used as more of a punitive thing, and it generally was seen as a kind of bad mark against an organisation, which didn't then set us up to have those open, safe cultures where we really could explore system issues in an open and safe way. So that's why we have moved. Sorry, I just got a bit of background noise there. So that's why we no longer talk about serious incidents, and the PSIRF is about all patient safety incidents. So we set out a new approach to achieving effective learning and improvement following patient safety incidents, and we hope that we can embed patient safety incident response within that wider system of improvement. So as Mark mentioned in his presentation, really trying to think about how the insight feeds into improvement in the first place, so we can start to see that sustainable change and improvement. We hope that it will support a shift in safety culture, as we've already mentioned, moving away from that reactive and bureaucratic approach and facilitating a much more proactive approach wherever we can. And I'll mention how we do that in a second. And just to say as well, I mean, it's absolutely brilliant that we're joined by Sue today from West Suffolk, one of our early adopters. But the testing and revision has been part of PSIRF right from the beginning, and will continue to be through evaluation of the implementation throughout the wider system. Next slide, please. I think there's animations on this slide, so you can just click through them. Thank you. So when we talk about PSIRF, we talk about these 4 integrated aims, which again you may have heard about if you've read the documentation and if you've heard any of our webinars before. So we have the overarching framework, and then that's supported by supplementary guidance, which is centered around these 4 key aims. So the first one is the compassionate and engagement involvement of those affected by patient safety incidents. This is so important. And the more we talk about PSIRF recently, the more we have focused on that need for that open engagement right at the start, and that not being sort of bounded by any particular thresholds of harm. So under the serious incident framework, something was declared a serious incident, and then that would trigger a process of RCA and engagement through that process. But under PSIRF, what we're saying is that we can always have an open conversation with anybody who's been affected by a patient safety incident, using that term, those affected in the broadest sense, patients, families, staff, friends, to answer questions, and where there is a learning response, to engage those affected in that response as well, and to make sure that their insight is part of that process. But just to note, of course, that our guidance doesn't affect anything in relation to duty of candour, but can support it. And what we hope it will actually help that more sort of human-centred, open conversation. I think that's actually what staff within the NHS can often do really, really well. But sometimes the SI process and this label of investigation and RCA is sometimes inhibited that just human to human interaction in an open and supportive way. So the second one there, the application of a range of system-based approaches to learn from patient safety incidents. So as well as moving away from SIs, we no longer talk about RCAs as the preferred method of doing investigation. And that's because, as Mark said, it has encouraged a very linear approach to investigation, where we sort of describe a problem and then move to solutions. And we kind of on this conveyor belt of doing investigation after investigation. So we want to use a range of approaches that follow a systems-based approach. But some of those approaches, so we've got a whole learning response toolkit that is available for organisations to use. Some of those can actually generate insight far quicker than an RCA ever could. And it also allows us to, as it says there, use an incident as a window on a system. So you don't have to look at every incident individually, and you can look at incidents more collectively. And that comes into the considered and proportionate response to patient safety incidents. So there are still some national requirements for certain incidents to be responded to in a certain way. So never events, things that meet the learning from deaths framework, but those must-dos are kind of very few and far between, and everything else is for the organisation to decide how it's going to respond to. And that's done in collaboration with stakeholders through this process of developing a patient safety incident response plan. And this allows organisations to balance the resources that are invested in doing the response and doing the improvement. I think there should be another animation if you could click last one. And then the final one is linked to supportive oversight focused on strengthening response system functioning and improvement. And this talks about how our whole oversight system is changing, which I'll come on to. So next slide, please. So I mentioned we don't expect organisations to implement PSIRF overnight. I know that's often how national policies arrive. They're published one day with the expectation of implementation the next. That's not the case with PSIRF. We published the guidance in August. And we've been on this journey of preparation, and we have a really detailed PSIRF preparation guide, which has been developed with the thanks to our early adopters and their insight. And they have told us the things that would have helped in that sort of transition phase. What's the work that we could have done at different phases to understand our systems, to get us into the best possible position to be able to transition to this new way of working. So that's what the preparation guide is trying to do. And I know everybody will be at different stages, and there are huge pressures in the system at the moment, but hopefully this gives organisations a structure to work through, and something for us nationally too to structure our support around. So next slide, please. So what does this all mean for provider boards? So if you've read our oversight roles and responsibilities specification, you probably would have seen most of the detail already. So that the PSIRF and specifically that oversight roles and responsibilities document asks for the appointment of an executive lead within an organisation, and that lead being a member of the board or equivalent leadership with responsibility for probably quality or patient safety more specifically. So generally, I imagine it would be the person that is accountable for the serious incident process now, and probably would take on PSIRF as that role evolves and changes. But there are some really important changes that PSIRF brings to those to those who are accountable for PSIRF in provider boards, because the provider board under PSIRF is now responsible for the quality and sign off of patient safety incident investigations and learning responses more broadly, and for making sure that PSIRF is central to that overarching safety governance. And the interaction with integrated care boards too, trying to enable that partnership working, development of plans together, thinking about where there are cross-system issues where you can collaborate with others across your system. That's all really enabled by the supportive work that the board can do. And then the ICB takes on a very different role compared to that under the SIF, where they're working with you to develop plans, and they're asking questions about the strength of the patient safety incident response system more broadly, rather than that check and challenge that we used to see under the serious incident framework. Next slide, please. Why did we make this change? Probably fairly obvious, but it's the importance of the board or the executive leadership. You as board members hold a huge amount of influence on how your organisations respond to incidents. And there's a quote here, and it's recognised in literature, that it's the occurrence of incidents does not differentiate healthcare organisations in relation to patient safety, but the way that they respond to them does. I know that's not sometimes the way it's perceived when there is an over focus on numbers and benchmarking against SIs, and that's what we really want to move away from, and support a far more open, curious response to incidents. And if we go on to the next slide, there's a better way of illustrating that. We know under the SIF, and I'm sure many of you will be familiar with the work that Mary Dixon Woods and colleagues did in 2013, looking at culture and behaviour in the NHS. But we know that the serious incident framework hasn't enabled this problem sensing approach that we would really like to see, that allows organisations to be focused on intelligence gathering, conscious inquiry, and organisational sense making that it sort of suggests there. Instead, under the serious incident framework, we were encouraged, as boards were perhaps encouraged to be more comfort seeking. So there was lots of focus on the process measures, 72-hour reporting, completion of 60-day reports. Being on this churn of doing investigation after investigation meant that there wasn't the time to do that really in-depth system analysis. So obviously that brings in the problem where you articulate problems, and then there's this magical leap to solutions without that really in-depth understanding. And also, as I said before, that sense of being judged and SIs being a bad thing doesn't enable us to be open, or it doesn't encourage us at least to be open about opportunities to learn and improve. Next slide, please. So we're hoping that PSIRF can change this, and that's been the focus of that oversight guidance that I mentioned before. And this is that is all underpinned by these oversight mindset principles and the oversight approach principles that you can see here. I won't go through those in detail in the interest of time, but this should underpin everything we do in relation to oversight at every level of the system as well. So not just boards, of course, but ICB, CQC. We've been working with coroners so that everybody understands the message and the ethos behind PSIRF. Next slide, please. There are some training requirements that are introduced with PSIRF, and I think this is particularly important for those in that lead oversight role, because this may be new, or it might not be something that's been an area of focus before, but because those in leadership roles, those who are leading that oversight, do have such an influence on the way that this process and this framework will be implemented, the training and the knowledge is really important. So as it says on the slide here, there's the kind of systems approach to learn from patient safety incidents, the oversight of learning from patient safety incidents, and the involvement of those affected. They are all sort of training requirements alongside the patient safety syllabus training, which is e-learning. Different ways to approach training. We've got HSIB will offer free training. We've got a list of quality assured suppliers. Obviously that comes with a cost, so if you can do training at scale across systems, working with ICBs, that's really helpful. Yeah, we might have some more questions and time to talk about that later. But next slide, please. There are a very different set of questions that the Oversight Guide outlines for assessing the strength of your patient safety incident response systems for the future. So we've moved completely away from numbers, dashboards, RAG rating around 60-day completion. And now the questions are focused around these really fundamental aspects of a patient safety incident response system. And there's questions in the Oversight Guide to sort of probe those areas. Boards can take different approaches. You might choose an area of focus every quarter, every so often. It might be aspects you explore through a board or sort of sub-quality committees in a structured way. But as you can see, these really start to test some of those aspects. So, for example, the engagement and involvement of those affected. How do we ensure that those affected by patient safety incidents are engaged and involved in any learning response? Does engagement include prompt and effective communication between those affected by a patient safety incident and our organisation? Going down to the competence and capacity, are training and competence requirements met for learning response leads? So we can really start to delve into the systems and processes you have in place. Next slide, please. So what could we be doing now? There's absolutely, there's a huge amount of work going on in relation to PSIRF, but we're aware that that's happening against the backdrop of incredible pressures. We're really aware of that. We've tried to make information as accessible as possible, and we know organisations have PSIRF leads working alongside executive leads to deliver PSIRF, but it's really worth you as board members understanding PSIRF. The Oversight Guide and the Preparation Guide are the sort of key documents we'd recommend, and there's a really short animation that hopefully explains PSIRF in a few minutes, probably more succinctly than I have just done now. But to really think about how the board can support those PSIRF leads or teams throughout the preparation phase, potentially even thinking about your project management office and where there might be support to see this as a programme, to really think about how to make the most of this time that we have for preparation. And now we're in this sort of diagnostic and discovery phase, moving into governance and quality monitoring. It's a really good time for boards to engage in the questions that sort of assess the processes you've got now and see where the gaps are and where you may want to fill those and how, so that you're ready for PSIRF later on in the year. And the other thing to say, because I know there is so much going on, there is a real opportunity to think about where PSIRF can help some of the other programmes that might be going on in organisations at the minute. So, I know many organisations will be responding to the Ockenden immediate actions. PSIRF is actually very supportive of many of those in relation to incident management and learning. And we're working with maternity colleagues to support and demonstrate that. There's also lots we can do in relation to kind of things that will often drain your resources in relation to SI backlog. So we know at the moment a huge number of ambulance delays are being reported as SIs. We've got SIs in the emergency departments. All incidents that are being looked at individually, generating individual investigation reports, individual action plans. And PSIRF allows you to take a very different approach where you can, as I say, use an incident as a window on the system. Down in the southwest, there's been lots of work to look at ambulance delays in a kind of more collective thematic approach rather than trying to tackle each one individually. So that it's worth thinking about where PSIRF can help with some of the other programmes that are going on. And just to say as well, to link with ICBs and start that conversation, as Mark said, hugely important that you have their engagement and to use the channels of support that are available. I'll pause there in the interest of time and hand over to Sue.
Thank you very much, Lauren. Hello, my name's Sue Wilkinson. I'm the Executive Chief Nurse at Suffolk Foundation Trust. And I'm going to give you a brief overview of our story being an early adopter for implementing PSIRF. That is to say, this is the way we did it. It's not necessarily the right way, and we still continue to develop and learn as we go. It is really an iterative process. Thank you. Next slide, please. So, as an early adopter, we were introduced to this programme in 2019, just before the pandemic hit us, and we were one of 4 trusts within our region to do this. The initial project was led by our previous Deputy Chief Nurse, and initially there was a presentation to board which involved parties including our governors and Healthwatch Suffolk. Initial decisions following this presentation were that there would be funding provided to support some additional posts, and those were our 2 patient safety investigator posts. That we confirmed that we needed project leads, and 2 senior members of the patient safety and quality team were identified to take these roles on. There was divisional and multi-professional input held through a task and finish group, which was chaired by our trust secretary. However, as you'll all know, we had a national pause due to the COVID-19 response early in 2020. Next slide, please. So, during the national COVID pause, we did continue to work on our development of our plan and the analysis that underpinned it, but it was in a more informal way rather than structured. There were several reasons for this. The board and the main organisation's focus was to manage the pandemic, and in fact one of the co-leads was moved to work clinically to help support our COVID response. There was no national scrutiny at the time, and reporting during that time, although the CCG, now the ICB, were maintaining contact with us. If we were going to do the same project now, we'd want to have a much greater degree of board scrutiny. I think it's fair to say that the board were not as focused on this as perhaps they might have been, but again, that was due to the competing priorities of the pandemic and other issues that were arising at the time. There was lots of change locally throughout this year as well. The exec team underwent a total change. So I came into post in 2020. We've had a new CEO, we had a new medical director, we've had a new chief operating officer. So as you can see, there's been lots of change from our personnel perspective. But I think what that's brought is really good insight and new ideas and engagement and real enthusiasm to take this further. We also, in that time, set up a new assurance committee structure, which is based on the NHSE patient safety 3I principles. So we now have involvement, improvement and insight committees, which are our board assurance committees. We do now have regular updates for the board, and I think it's fair to say that our board ownership and understanding of the programme is now fully embedded, and our board are really committed to working with us to help deliver and evolve this even further. We are still developing our processes. We sort of set up about a 3-stage process in the initial thing. Oh, could I have the next slide, please? Sorry. I need to keep up with myself. So the first stage was to set up something we call an emerging incident review panel. We agreed that we would do this weekly. We agreed that any potential near misses or incidents that were rated for potential moderate or severe harm would come through this panel, and any others that we may be concerned about. And that includes our maternity cases, which was a big step for us in the right direction. The Emerging Incident Review Panel is attended by myself and the Medical Director or his deputy, and our Chief Operating Officer, and any other execs that wish to join us. We also have a member from the ICB in attendance, and they fully participate in our discussions and are really a brilliant resource as a critical friend, and to help us have those really some of the very tricky conversations that we might need to have. Important to note that we do not chair the meeting. It is chaired by our Head of Patient Safety and Quality. I think it's also important to note that we have really, really good attendance at these meetings from our clinical teams, but we do work really, really hard on making sure, as already alluded to, that these meetings are not a reporting process for people to come and identify individuals or B, sort of specifics around the incidents. It's more around the systemic approach, the context, and how we can support those people involved in those incidents. So we look at the whole process. We look at what's happened. We have a supportive conversation. We really do aim, our culture is to try and have compassionate leadership, and we really aim to emulate that throughout the meetings. And then what we do is we all discuss in the meetings and determine the most proportionate investigation pathway for whatever has happened. The duty of candour, we kind of focus on duty of candour, but we like to think of it more about being open and honest with our patients and our staff. And we also make sure that we identify the appropriate person to undertake whichever route we decide on to look into those incidents further. But we also make sure that those staff that are involved in the incident are engaged in the process, but also are offered some significant support, because we understand that any incident can cause patient and staff harm from a psychological perspective. Nobody deliberately does anything wrong. Sometimes these things happen. Following on from that, and our closed board receives all the details of the cases that we discuss through the Emerging Incident Review Panel. Going on further from that, we set up a Patient Safety Incident Review Panel. And that panel, again, is made up of execs and people that have written the reports. And what we do in that, we review the reports that have been written. We ask questions. We assure ourselves that the patients and staff have been appropriately informed and part of the process of investigation or review. We're trying to move away from language that can imply that somebody has done wrong. So we're trying to use words like review, reflection, oversight, rather than witness, statements, etc. During that meeting, we read the reports, we agree whether or not we think that they're right, we try and identify where there is learning, and we have, as I say, multiple invitees, and it's just to make sure that the reports we're writing are of high quality, and our investigation, and we're assured that our investigation processes are of good quality. The next stage is stage 3, and we're still developing this. We recognise that it needs more work, and we're using a QI approach for organisational wide issues to ensure sustainable change. It's our safety improvement group. It's a different to a tick box approach to action management, and what we want to be able to do is make this an iterative learning, a cycle that keeps going around, so that we can reflect and we can go back and we can make sure that we are making differences. And the benefit of this is that we can then absolutely assure ourselves that organisational learning has occurred. Next slide, please. So, our advice to boards. Well, consider the financial implications and resource commitments up front. We really do need the resources to enable this to do. It's not an added on to somebody's day job. It does need to be their role in its entirety. And that enables us to design the systems, and it gives us realistic expectations. Empower the subject matter expert and project leaders. So you do need, as already alluded to, you need executive support, you need board support, you need sufficient time and resource to deliver this. And it's absolutely essential to have links with key stakeholders. We need to agree, it's important to agree board oversight requirements. And as I said, I'm not sure our board was as fully cited at the very first part of this process as they are now. I hope that people who speak to our board members now, that they would be aware and fully cited on the processes that we've got in place. And, you know, to provide assurance and enable education, it's a two-stage thing. We need to develop it, and then we need to have that sort of oversight arrangements and requirements. And as I say, our plan is to include all executives, not just the safety and quality lead. It could very easily just sit with me alone as the executive lead for patient safety and quality, but I don't feel like that. I feel it is equally shared amongst my colleagues, and we have real engagement, I think it's fair to say, from all of our executive colleagues. And we also have great support when I present at the board. We do get a great support from our board colleagues. It's easier to spot trends rather than working in silos. When you've got the number of people in the room, what you can find is that people's recollections are slightly different. And it's a really good opportunity for somebody to say, hang on a second, I might have heard something very similar to that before. Can we go back and have a look at that? Can we look and see if there's any trends going on? And it links to operational focus. So it's not just about what's happening in the clinical settings, it's how the operational pressures and things are impacting on our ability to deliver safe patient care of a high quality. And it also helps the wider understanding of our PSIRF and different SIF programs. And there are a lot less patient safety investigations than SIs. And again, sometimes it's a little bit about how do you manage the boards and external partners, expectations of, you know, what if we're not recording an SI, how are we going to robustly manage it? And part of this program is to help us explain and to be able to deliver that assurance that we are taking it and we are doing it in a really quality improvement approach rather than a tick box, bog standard transactional action plan, as it were. So change of mindset, supportive systems. It's not about investigating people, as I've already said. It's about investigating the incident. And I think that's really key. And that's what we've learned as an organisation. And our staff are still struggling. It's fair to say some staff are still really struggling with that concept and do feel really personally responsible. And it's our role as senior leaders to absolutely reiterate, this is about the system. It's not about the individual. It's about how we can change our systems and processes to enable all of our staff to do the right thing at the right time. And the other thing that's really, really important, and especially in the emerging incident review panels, is that element of psychological safety. It's a word people use a lot. Do you feel psychologically safe? It's really personal to everybody. And we've seen a number of behaviours and we've seen a number of reactions through our panels. And each time we do, we learn from it, we reflect, we go back and we think about how could we have done it better? How did it make that person in that panel feel? So as I say, it's an iterative learning approach. Thank you.
Thank you, Sue. We'll move to the Q&A now. We've got some really good questions coming in, so thank you very much. Do keep them coming via the Q&A button at the bottom of your screen in the middle. I've got a first couple on wider engagement that I'll take together and direct towards Sue initially, and then Tracy, Lauren, you might like to come in. One is around engagement with Foundation Trust governors, as they need to understand this change and therefore how are they involved and ensured? Do you have any do you have any reflections on that? And also around coroners as well. We've had a couple of questions around engagement there, particularly because traditionally root cause analysis for individual incidents has provided key information for coroners. So have you had any engagement there? And that's to Sue initially, please.
Thank you. So I think I wasn't actually present at the very beginning in 2019 when we started the initial communication process, but my understanding is that initially our foundation governors were involved, but as you all know, during COVID, unfortunately, due to sort of different levels of focus and different communication channels and the lack of face-to-face meetings, I think it's fair to say that we possibly didn't communicate as well as we possibly could have done. And we are now sort of trying to regroup and get back onto an even keel with our governors But absolutely, it's essential that they are communicated with and feel part of the team and have their views as well. And so we are trying to work really hard with them at the moment. But I think it is fair to say that possibly at the beginning we didn't involve them, or we did, but we didn't continue that involvement due to what was going on nationally.
Thank you. Lauren, Tracy, anything in particular on your relationship with the coroners?
Thanks, Meredith. Sorry, it's taking me a while to get off mute there. Yeah, really, really key stakeholder, coroners, and we're aware that coroners' expectation and the fact that they have generally received RCAs for the deaths that will go to inquest has a huge bearing on processes. I think the work that we did with our early adopter organisations was really enlightening, because the power, I suppose, of local conversation and engagement with coroners is really, really important. We met with the chief coroner whilst we were developing PSIRF, who was really supportive actually and on board, and we've met with them again since. Our director, Aidan Fowler, who's the National Director of Patient Safety, is attending the annual Coroners Conference, I think it's in March, to continue sort of promoting the work that we're doing and to make sure coroners are aware. Tracy and I are also getting out to groups of coroners wherever we can to talk about PSIRF and how it is changing, and how we are not changing the expectation that coroners receive the information that they need. It might not be in the form of an investigation report, of course, where we've got one. We should always be sharing that with the coroner, as we always would. But where we're not doing an individual learning response and the coroner still has questions, we would still continue to answer those, generally through the legal teams. And we've been talking lots to groups of legal teams too, to think about how their processes and how they might directly answer a coroner's questions in the absence of a specific learning response. And generally that's been working quite well. And I think over time, I think some of our early adopters had a greater challenge than others, because every individual coroner is different, as you'll all know. But as we all start to work towards this approach, it will become the norm. So it will become, I think, less of a challenge, but definitely engage locally, have those conversations, so that coroners don't feel caught out. Not that they should, because I think there's been lots of engagement, but it's always worth having that conversation.
Thank you. And a question which I think will resonate on the balancing act of the rollout. Tracy, Lauren, is there a view on the required resource to introduce, operationalise and embed PSIRF in, for example, a medium-sized foundation trust?
I haven't got hard numbers. I wish I did, because I've been asked this question a lot. The challenge for us when we set out on PSIRF was to try and make it cost neutral. So there was no expectation that organisations would have to employ new staff. But of course, as with any new programme, new way of working, some organisations, our early adopters, as Sue has just explained, did make changes to the organisation, put cases forward to recruit new staff to support that brand new way of thinking, where there could be experts in sort of systems thinking, system analysis come to help this programme. That's been hugely beneficial. Organisations don't have to do that. We're not starting from scratch. You will have, I'm sure, patient safety teams, those who do investigations now. It might be more of a case of really thinking about, who's there, who's doing what, are there training needs? I appreciate there's always a cost, or even if it's in terms of time, not money, to support those staff, but that can be sort of managed through ongoing professional development anyway. So there are different ways of doing this. Some organisations have found it really helpful to have dedicated kind of project management support for this. So I think if you've got capacity to enable that, brilliant. But as I say, the kind of preparation guide and the way that we've approached PSIRF implementation is trying as far as possible to be cost neutral. Obviously, it depends where you're starting from, and if you've got gaps in terms of expertise, then there probably will be a cost in terms of how we fulfil the need to have that resource, but generally it's about just looking at what we have and trying to evolve and develop that.
Thank you. We've got a lot of questions coming on governance. I'll group those together in a moment. But first, Mark, I'll come to you. Question around when it became, what do you think is the turning point that people see for the board and executives realising that engagement is required to support rollout? Any reflections there, Mark?
I think my reflection is it's very important that boards, senior managers, executives understand that you've got to put the people involved, your staff, patients, families, carers, at the heart of what you're doing. And one of the big things for the reports when an investigation occurs is the fact that the patient or the family get to see a draft. They are involved at the start to check that they understand what's going on, what is required from that. They see the draft and they can comment on it. All right, when we had the early adopters starting, there was the thing, well, what if they don't accept what we've written? Well, discuss it, go through it, but you might then have to put in the report, this is what the family said and thought, and this isn't the case. The thing we got wrong, and I got totally wrong on the reports, is originally we thought, well, the executive summary would be what most families or patients would look at. We got that totally wrong. They've really been fully involved with the early adopters in the whole contact, what was going on. So, yeah, and it can be a bit frightening for boards to start with, but you get the insight of how it's affected people.
Thank you. I'll just turn to that set of questions we've had about governance, in particular non-executive directors, and I'll turn to you, Sue. You might like to reflect similarly on where Mark has just focused, but the questions we've had around how non-executive directors have been made part of the system, what reports they have, how do you enable them to provide scrutiny?
Thank you. So our non-executive members of the board do chair our 3I committees. So we have a chair on each one of those through improvement, involvement and insight. We do take, as I said, we take a closed board report that contains and details of all the cases reviewed through EIR, and the non-execs are present at that. And I will update on specific cases, especially if it lists something that seems that they're not aware. We do try and make sure that if there is anything significant, that through our communication system, we try and inform our governors and our non-execs of anything that may be, slightly more sensitive that they would want to be aware of before it goes to board. We also have our open board report, which contains details for our learning outputs. And that's also captured in the wider integrated quality and learning report. And I think it's that day-to-day conversation. We have invited our non-execs, especially as we've recently recruited a number of new non-execs. We've invited them to attend our emerging incident review panel so they can witness, they can see what goes on, they can feel it, so that when we go to board, it's been brought to life. It's not just something that's a process that's written on a piece of paper and then is articulated by myself. It is something they may have experienced themselves, and actually, being able to question and explore. And I think that's really, really important. But, it is imperative that obviously everyone's informed all the way along the line.
Thank you. And then Lauren Tracy, we've had a couple of questions about health and safety committees and how they provide oversight and constructive challenge.
Sorry, Farrell, I think my sound was breaking up a bit there. I think I've caught that though. And Tracy, please do jump in. I think there are different ways of doing this, whether it's sort of health and safety, quality, governance committees, and under PSIRF. Well, my recommendation, I would say this, wouldn't I? But is to use the oversight guide that we've set out to try and look, because we can look at individual cases and the processes that we have in place, and that's very important, but also to focus on those fundamental features that I talked about earlier of a patient safety incident response system, to really assess how we're doing the engagement involvement piece, to assess that kind of training and capacity and competency of those that are leading learning responses, those that are supporting or engaging those affected, and also the kind of the how all this fits together across our wider organisation. So that process of finding the insights from our learning responses and using that to inform organisational improvement planning as well, and making sure those connections are made. I think that's where our committees can really help to join the dots and facilitate that collaboration across organisations too. So that would be my recommendation.
Thank you. I think we've got time to squeeze in one more question. And one which a number have been concerned about, and I'll go again to Tracy and Lauren, please. From a data perspective, would the data that is currently being captured under the serious incident regime get repurposed under the PSIRF, or is there a whole new data capture requirement under PSIRF?
That's a great question. No, it won't be repurposed, because there'll be no such things as SIs. So the SI dashboard and the kind of, sometimes we see organisations being performance managed on those and being classified as outliers for under or over reporting of SIs, that will not exist anymore. And of course, we won't have those tables. I don't know if they existed everywhere, but I've certainly seen them in lots of places where commissioners would often have reg rated against the time frames for completion of investigation reports. They won't exist either. It will be really interesting to think about the data and the numbers and how that's applied to PSIRF. At the moment, what we see is a far more qualitative conversation about how we manage incidents, how we respond to them, how that insight is leading to improvement. And of course, measuring that improvement is always the challenge, and often needs specific bespoke metrics to do that, rather than relying on incident data. But no, I think it's a brilliant question and a brilliant point. We won't repurpose or use SI numbers in any way. It was never a good indication of safety performance. So thank you for the question.
Thank you. We are on time, so I will close us there. But thank you again to all of our speakers and all of you who have made time to join us today. It's very much appreciated, and I hope you found it as valuable as I have to listen to Mark, Lauren and Sue, and to hear that discussion as well. And thank you for sharing your experiences. We'll be in touch shortly to share the slides, and we'll also share the recording shortly as well. And we'll keep track of all the questions you've raised, because I know we didn't get through them all. So thank you very much again to everybody, and please take a moment as well, because there should be a poll coming on your screen shortly. Thank you.